Good afternoon, everybody, and welcome. My name is Elizabeth Breidenbach on behalf of NAC. Thank you so much for joining us. It is 3 p.m. Eastern on our end. We're going to give things about 30 seconds. Zoom is taking people from a virtual waiting room into the main session. So thank you guys for joining us. Again, my name is Elizabeth. We're going to get started in about 30 seconds. Thank you so much. We're going to get started in about 10 more seconds. Again, thank you guys so much for joining us. Should be able to see slides on the front of your screen. Should be able to hear my voice as well. All right. In the interest of time, let's go ahead and get started. Good afternoon and hello, everyone. Welcome to today's session for the Million Hearts. My name is Elizabeth Breidenbach. Thank you so much for joining us. I'm going to go over a few housekeeping announcements before we get started today. Friendly reminders, today's event is being recorded and will be available for on-demand viewing at a later time. Again, today's event is being recorded. All attendee lines have been muted. Video has been muted as well. This is really just to avoid any sort of background noise interference, but you should be able to see all of our fantastic panelists today, audio and video. Q&A box is open. It's going to be open for the duration of this event, located at the bottom of your Zoom screen. You may need to take your cursor to hover, or I like to say wake up Zoom, so you see that function, whether it's a widget or if you click the more button, it's 3 little dots, click that and you should be able to see the Q&A. You can type your comments, questions, or concerns into this box at any time. You can also upvote questions, any questions that you see in that Q&A box that you want answered as a priority item. Please use that kind of thumbs up. It upvotes things and lets us know that that's a priority question that you'd like us to respond. We'll also be using the chat privately for you guys. Again, you guys will not have the ability to type into the chat, but we'll be submitting some resources for you, links and things like that in the next 45 minutes of today's session. Next slide. And at this point, I'm going to turn things over to Meg, who's going to be setting the stage and introducing today's speakers. Meg, the floor is yours.
Thank you so much, Liz. Really appreciate it. So I'm Meg Metter, Director of Clinical Integration and Education with the National Association of Community Health Centers. And I'm very excited actually to bring you this session. It's a really unique and I think timely session called Managing Cholesterol Using Technology. And we've got 3 great panelists that will be speaking today. I will be introducing each of them in just a moment, but I want to give you a little bit of an overview of how these learning labs work. So they're actually divided into 3 parts. So we have 2 pieces of pre-work. One is about a 10 to 13 minute recording. So it's sort of that micro learning technique. We ask folks to listen to that to kind of tee up the topic, tee up some questions you might have. And then that goes with a short survey where we gather the questions that you might have based on the recording and for our speakers, so that we're able to really focus in on the live event, which is the 3rd part of this session, or the way that we design this series. It's basically just a bit of a review by each of our panelists, and then most of the time is focused on Q&A. And so I think we found that it's a very valuable way to format this. And then for clinicians, this is actually equivalent to 1 CME credit. And we're going to tell you at the end of this session how you can apply to earn those credits. So we have 3 learning objectives for today. The first one is describing how 2 health centers are using technology and telehealth to manage care for patients with very high cholesterol and to increase evidence-based prescribing of statins. And then the second learning objective is identifying those key components of workflows and patient care models that enable successful chronic care management, particularly obviously around patients with very high cholesterol. And then the third objective is discussing how the use of technology can address patient barriers to care and then inconveniences related to statin therapy prescribing that might also be barriers. So our 3 speakers today come from health centers on opposite coasts of the country. I'm going to start with Mike Farley, who's a pharmacist with Winding Waters Medical Clinic. And then Vito Zuna is going to follow with Zufall Health Center, and he is joined by his colleague, Milibeth Castro. And we're very excited to have all of them share with you today. Mike's going to start, as I said, he's going to talk about point of care lipid testing, and then Vito and Milibeth will talk about cholesterol management using telehealth. So at this time, let me turn it over to you, Mike.
Hi, thank you. And yes, my name is Mike Farley. I am the clinical pharmacist here at Winding Waters Community Health Center, and located in a very rural setting of Northeast Oregon. So we have about 7,000 folks that live in the entire county that we serve. I am fortunate to be part of a team of 9 physicians. We have 3 physician assistants, 3 nurses, 3 behavioral health counselors, and 3 dentists and a full dental team. So we're fortunate to have a pretty well integrated team-based practice here in a frontier medical setting. And I'm excited to share with you today some of the successes that we have had in improving statin use and cardiovascular outcomes by virtue of having a point of care lipid machine worked into our workflows. So we can go to the next slide. So our initial plan was to take a look at those high-risk statin groups that were illustrated in the pre-session video. So those patients whose LDL was greater than or equal to 190, or patients with diabetes that aged 40 to 75 with elevated LDL, or those that were over 21 with a cardiovascular diagnosis. So we began kind of our project here looking at those groups and having our data folks create some gap lists for the team. And based upon those gap lists, then we began reaching out to those patients if they were not yet on statin therapy, and try to engage with them, have them come in for a visit to be able to talk about getting started on a statin. And it gave us a chance to kind of get one more touch with those patients. And as you might imagine, we had some luck with that, but doing outreach of this nature is often mired with difficulty reaching the patient, or patients, saying okay and then never scheduling or not following through. So while we had some success, I think our biggest success came with sort of our phase 2 of the plan, and that's on the next slide. We began really focusing on this during scheduled clinic visits and doing some chart scrubbing each morning, taking a look at best practice advisories in our health records, and looking at those who were people that were in those categories that in their appointment note, we would put high risk lipid. And that was sort of the flag to the provider for that visit, that they needed to touch base and talk about their cholesterol levels, as well as, the increase toward their cardiovascular risks, and be able to have that really one-on-one conversation about needing to get started on a statin and to address any sort of hesitancies that patients had or concerns that they had. And as a way to kind of reinforce that, we made use of a point of care lipid machine, which allowed us to do a finger stick test and get the result within a few minutes right during that visit, to kind of reinforce the concerns that we had for the patient, and to help us to be able to set some goals for therapy, as well as bring in either myself or one of our nurses to kind of talk more about some lifestyle modifications. And if diet was a big issue, as it is with most patients, we were able to then do a warm handoff to our health coach that's on the team to kind of further take a look at some meal plan changes that patients could make. We also created a dot phrase that could be incorporated into each visit that allowed and guided each of our providers at setting those goals, as well as follow-up plans that made it effective for us then as we continued on to make sure that we're following up and getting the outcomes that we were looking for, and provide that level of consistency between providers, which turned out to be pretty successful. And next slide then. So this is kind of our setup. The picture on the left is the lipid testing machine. And it, as I say, involves a finger stick. Technology or technique was a little bit of a challenge in that you can see it uses these little glass pipettes. And so there was a bit of an uptake in us training the staff on the proper technique to obtain the sample in the most simple manner. And it takes a little bit more blood than it does for a point of care glucose test. So getting the pipette just in a parallel position to the blood droplet so that the wicking nature of it would be effective did take a little technique refinement. But once we got onto it, it was a simple process that we were able then to use the little cassettes contained in that package to collect the sample, and then we place it in the machine. And within about 3 minutes, we would get our result that prints out in the printer you can see behind it. And we were so successful with doing point of care in this way that it actually caused us to do a little research and expand our point of care capabilities to the machine that's on the right that can also do a CMP panel, which then we've extrapolated the successes from our lipid monitoring into things like if we want to do a follow-up check after starting a blood pressure medicine and make sure that we're not doing any ill effects to kidneys, we can run a point of care CMP. So that's probably a great discussion for another day. But I bring this up just to point out that when you get started with one of these pieces of technology, the possibilities can expand to further benefit you in your patient care. And next slide. And so lastly, what were the results that we got from incorporating this point of care technology? Well, we were increased the number of patients who received statin therapy because we were able to have that discussion and we were able to get a lot more effective follow-up with patients and give them that immediate feedback on the benefit of the statin therapy at follow-up visits. It became a great opportunity for us to leverage our team-based care approach to bring in the right people to help address hesitancies toward therapy and reassure folks that statin therapy was indeed an excellent addition to their regimen and that we had benefits that expand beyond just lipid control. As I say, we wound up adding to our portfolio of point of care machines as a result of the success we had with monitoring lipids. And then we were able to increase follow-up and screening because of how simple it is to get that point of care result and just do a finger stick versus a full-blown blood draw. So it's definitely made an impact on our practice, and it's helped us to better serve our patients and to give that sense of value when a patient comes in for follow-up. They know that they're able to leave and know if their therapy is working. So we've been really, really pleased with the results and happy to have been able to share it with you.
Okay, so I'll jump in. Thank you, Mike. So my name is Vito Zuna. So telemedicine has been an excellent tool for us. Early on when I first started working in medicine, certainly wasn't something we have thought to even use, on a daily basis. And in the beginning it was hard and, sort of going through uncharted, waters and it seemed to have significantly improve our way of treating and aiding patients and compliance and things like that. So to go into it in terms of identifying patients, as usual, you do your labs. It seems like we've had a high influx and a lot of physicals, a lot of new onset diabetics, and for some reason, I guess people are more health aware because of the pandemic and everything. Seems to be a high influx. And so taking advantage of this, we try to get labs on these patients, and obviously identifying those high risk patients are is a key, right? So as similar to Mike, we sort of note these patients who are high risk, your LDL is above 190, your diabetics, usually they're not on meds sometimes when they come in, or obviously if they're new onset. I don't always try to throw all medications because it can be a little overwhelming. So I like to take it step by step, but patient seems to work. And it seems they seem to respond well to that. And obviously your clinical ASCVDs, and usually they come in already from stroke rehabs or from the hospitals. They're already usually on statins. Of course, we make sure that they continue them. But then we have your group, you're above 7.5 ASCVDs. For your fourth group that we saw on the video, I like to focus on them. So usually, we have these labs in, they come in, on our EMR. And obviously, after identifying, we send them over to our front desk, those patients who would like to, have a telemed visit to further discuss this. So if we go through that in terms of scheduling, we try to, next slide. Yeah, nice. So what seems to work really well is sort of blocking these patients in one blocks. If you schedule them throughout the week, then sometimes you can lose track, because of course telemedicine, it's not 100%. A lot of times they won't answer the phone even if they're scheduled. And so putting them all in a block, usually I have Tuesday afternoons where we do these types of visits. For those patients who don't answer the phone, if we won't have the visit, it won't be, checked out. So then we know to hopefully reschedule them and make sure to keep track of them. And it seems to have worked really well, because, eventually we make sure to get them. And that's always an obstacle a lot of times when they don't answer the phone, even though they've already been scheduled. But certainly making sure that that's something we do with blocks makes it effective. Next slide. So sort of the workflow in terms of scheduling and getting these telemed visits, obviously after I identify patients, then we send them out via telephone encounters through the EMR to the front desk. They've been really good in sort of communicating with the patients, obviously making sure that they have a cell phone and that it has an ability to provide camera and audio, and obviously making sure we have the correct phone number. Usually they're notified, and I think reiteration makes a difference in terms of repeating things to patients, because a lot of times, this is all news for them as well, right? So, reiterating, you'll get a phone call from the MA, to do usual triage, because it is an actual visit. And then eventually, once they become ready, then I do send them a text. Then they're scheduled. So this is all prior to the visit. On the day of the visit, of course, they're called by the MA, they're triaged. Again, we tell patients, the MAs tells them, you'll get a text message, make sure you click on the blue link. And then, you'll have, and on the screen, it'll come out, accept phone, accept microphone, accept the camera. And usually it's pretty simple, and it goes through. So obviously, once that they're aware, I do eventually send the text message through the Oximity. That's the one we've been using at this point. And then obviously the visit starts, and once the visit is done, then the MAs or the front desk will properly contact patient for follow-up visits. Next slide. So the actual visit, right? The meat of this, the most important part, discussing all labs. Obviously, there's other labs that we do, not only lipids, and usually I discuss them. But obviously with a focus on lipids, because that's why they have the visit. They're the ones that were sort of identified as high risk. Of course, benefits and risks for statins, and we all know of them based on the video that we saw. The benefits significantly outweigh the risk of use of statins, especially obviously in these high risk patients. Discussing the role of statins. So I like to take a little time, and this is where it becomes effective, and this is what I've seen works really well. Taking the time to sort of explain. Obviously, we're not going to go through all the mechanisms and all the specifics. However, we make sure to instruct and educate patients on what the effects of statins and in terms of what the risk reduction they provide for these high-risk patients, right? And so we go through this, and it makes a difference. Obviously, there are always questions, there are always hesitations, and always these are the main obstacles, right? A lot of times they come and they're notified in the past, oh, statins will affect my liver, I'm going to get all sorts of side effects. And this is a time where we take to explain everything and go through all these questions, all these hesitations. And I think it's effective going through this, taking the time and explaining this is showing you care, right? And a lot of times patients come in and they're, all right, I used to have my doctor, they used to send me meds, and that's it. But if you take the time and you go through these things, and you show, look, I understand, you're concerned, you have these hesitations, but it makes a difference. It leads to trust, and that seems to lead to compliance with medications. Because if they can trust you, if they can understand you're taking the time to explain all this, it leads to good adherence. That's what I've noted. Okay, next slide. So of course, in anything, challenges, right? A lot of times they don't pick up the phone, and like I discussed, a lot of times it happens, and we try to reach out and reschedule with these patients. Of course, technology, it's beautiful when it works and very frustrating when it doesn't, right? So technology, even if we make sure that they have their phone in proper order, you have whatever the accessibility to the internet, and even that it leads to some difficulties, but we work through around it, and we try to make it work. A lot of times, even when the camera doesn't work, then we have to sort of resort to just a phone visit, but even that is effective. And of course, challenges in terms of hesitancy, taking statins, right? It's a new medication to a lot of them. But again, explaining and taking the time to go through all the specifics with them seems to make a difference. Next slide. Of course, the benefits of telemedicine. It allows you to have, the time to discuss with patients the specifics, right? And it's one thing where we used to sort of contact the MAs. Of course, MAs are amazing, but amazing part of the team, but it kind of sounds better when it comes from the person who's prescribing you these medications. And again, it reassures them that if you take the time to explain all this, it leads to adherence. So of course, it's convenient for the patient. A lot of times I've had these visits while they're at work. They take a little minute, and they go through these visits. So it's better, right? And making it easier for patients allows us to reach them, to get all this information across, and obviously for the purposes of adherence to medications. This one-on-one discussion, via the camera, it's almost like an actual visit, but it's sort of outside the routine of our regular diabetic or hypertensive or whatever visits, and that seems to sort of reassure them, we are taking time, we are doing an actual visit, and it leads to them to believe this is important, right? And all of that, our purpose is for compliance, because ultimately one of the biggest hesitant or obstacles in our realm is compliance, and it seems to be working based on what we've noted in the last recent couple months. Based on December 2021 to July 22, rates improved about 10 points, which seems to be effective. And obviously this is what we've been implementing with telemedicine, and it seems to be working. Of course, hoping to improvements, anything can improve at the end of the day, but telemedicine has become an excellent tool, and we're excited to see what it can continue to bring us in the future.
So thank you so much, Vito and Mike. Really excellent information. I'm super excited about hearing a little bit more from you, because I just think these are new technologies, and it sounds like they're making a tremendous difference. So Mike, you kind of alluded to this, but I want to ask you a question about sort of the challenges around getting started with point of care lipid testing. So would you say it was training your staff, or is it like the technical part of trying to use the machine? Can you say a word or two about that?
Yeah, sure. So as I mentioned before, I think one of the biggest steps in us getting fluent in doing this was indeed training our staff on the appropriate technique for capturing the sample and using the machine. And once we were able to do that, and it became second nature, then I think that the next layer of challenge that we had was to get everyone used to the fact they were there, and begin to incorporate them as in normal course of our visits. And so that, anytime we make a change in workflow, that takes a little extra time too. But I was pleased that the results that we got sort of expedited that, and it was a pretty quick uptake. So overall, it was a pretty low barrier to entry for us to start using this technology.
Great. And let me just ask you a follow-on question. So how are patients responding to this point of care lipid testing?
Yeah, patients seem to really like it. It's kind of nice for them not to have the standard blood draw in order to get the results. And they like being able to leave the visit knowing the result versus dropping it off at the lab and then getting a call later. And I think as providers, we like it because we can give that immediate feedback and celebrate the victories, and that encourages patients to continue on with the regimen and to improve their overall compliance. So they like it.
Super. Well, I'm going to shift to you, Vito and Milibeth. So one of the things that we've been sort of trying to emphasize in our Million Hearts project is that conversations about statins are not one and done. It's a continuing conversation. As you know, there are a lot of fears and hesitations around statin use. So sometimes it takes multiple conversations with that patient. And I'm just wondering, like, how does telehealth or telemedicine change that? How does it allow you to maybe continue that conversation in a way that you weren't able to before?
Yeah, of course, usually a lot of times during the visit, you present that, okay, in-house visit, right? Statins and benefits, and they're always like hesitant. And of course, again, with telemedicine, it sort of extends that ability to further discuss that and continue to talk of the benefits. And it's another level of ability to care and show the importance of statins. And that's the beauty of it. Telemedicine extends it to in terms of timing, in terms of explaining everything. And when you explain it and encourage everything in terms of educating patients, then they seem to be compliant to some extent. Of course, there's always those who won't, who still hesitate. And again, continuation is key.
Absolutely. And I have kind of a follow-on question that's for both of you around patient communication. We'll start with you, Vito and team, and then move to Mike. But so, it is something where I think words matter in how you approach this conversation. And so I would love to hear from you, like, best ways to communicate with patients about their risk and the benefits of statins, some tips, some nuggets and pearls of wisdom that we might receive from you about that.
Yeah, I mean, we all know risks, right? We all know how diet can be an effect, any comorbidities, hypertension. And so obviously going into those specifics and explaining how they can potentially increase risks, again, taking your time and going through those specifics allows them to understand the importance. And you mentioned, benefits, again, reiterating that fact of how statins, it's always a question whether, you want to undergo a little risk because you may get some muscle pains, and obviously that's not as common, versus, you want to risk your chances or reduce your risk of, experiencing any cardiovascular events. I mean, it's sort of like a no-brainer, and they come to that realization, and obviously it seems to be effective.
Super. Mike?
Yeah, I would agree. And then trying to have the patient be, part of the decision-making process too, and asking them, what do you worry about if you were to start one of these medications? And then sometimes it's nothing that we would even think about that would be a simple way, a barrier to kind of overcome for that patient. And I think also making sure that they're aware that there are more than one choice in the statin family that we can use. And just because they may have or may have had family members that have had issues with a statin in the past, that it's likely that we can find an option for them that would work for them, that not everyone is cut from the same mold. I think that's been helpful too.
Super.
I
Go
just
ahead,
wanted to,
Nola.
I just wanted to point out, I think it's also important to increase provider buy-in because that will help the communication. If the provider, mentions statin and then never brings it up again, it's pretty much what I'm saying is important to increase provider knowledge and having them being comfortable to continue having these conversations and having that open communication with the patient.
Great point, Milibeth. And I would expand that to even say maybe the entire care team bought in and understanding the importance so that everybody's sort of moving in the same direction. So we got a question from the pre-survey about age. I think this is, if I'm reading between the lines here, it's because people are sometimes concerned about particularly women of childbearing age. So the question is, what patient age groups are you targeting? And it would be kind of posed to both of you. But I think keeping in mind that that's the fear concern is women of childbearing age.
Yeah, of course, you want to reconsider, right, in terms of if they're planning on, getting pregnant in some near future, or are they taking, any sort of birth control. Of course, in terms of in general, age is based on what the recommendations suggest. Any LDLs, above 190, 20 to 75. In terms of challenges, the elderly population, in terms of when it comes to telemedicine, a lot of times they're not so technology savvy, and so it makes it a little difficult sometimes to get these visits, and sometimes you try to work with them as best as possible.
Yeah, I would agree to kind of work within the context of what the patient's overall goals would be, and yet find a way to give them all the information that they would need about lowering the risks that a statin can help them with, and then we kind of make a decision together. And so, yeah, I agree with what Vito said.
Excellent. I'm going to shift for just a moment and take a few questions that came in through our Q&A feature. Most of them are actually technical and really short answer questions for you, Mike. Just, the first one being, which EHR and or population health management technology or system are you using?
Yeah, our clinic uses Ocean Epic, which is a great tool that allows us, as I mentioned, with our data people, to be able to create gap lists for us pretty easily, and be able to kind of track our progress at contacting people.
And then a follow-on to that would be, how do you get the point of care lipid test result into the EHR?
Yeah, so our team was able to kind of configure it in a way that we order it like we would any other lab, and then we can just enter that result after we've ran the test. So
Super.
all
And
works
then
within the EHR.
two more quick questions on the point of care. The first one is, are these tests billable? And then the second question is are the CLIA requirements waived?
Yeah, so all the machines that we have in clinic are indeed CLIA waived. So that's been a big bonus. And then, yes, we've been billing as part of the visit. And I believe the majority of the time we're getting reimbursed. At least our billing people haven't raised any real concerns about it. So it's been that part, our time and supplies, the cost is getting covered for offering the service.
Super. And so I want to shift over to Vito again, just sort of in the whole, like holistically, what are some of the other interventions that you're exploring related to cholesterol management?
Of course, you want to always consider, and as we all know, lifestyle modifications, and a lot of times in itself, that's always a challenge to get that point across. And patients don't always respond. A lot of patients are busy, they're working, they don't have time to go exercise. And so the beauty here at Zufall, we have, besides, telling them patients, work on trying to increase exercise and work on your diet, we have nutrition. Nutrition, certainly is a aid in getting these, a little bit, with a little bit of improvement. We have referrals, and obviously telemedicine is used via that. So all these are aids in order to get, cholesterols to some degree of improvement on top of whatever statins are doing.
And just to add a little more, we also have point of care testing machines available at all our sites. We also are starting a pilot program with one of our labs to assist us with any clinical decision support. And then we also, as Vito mentioned, we have a multidisciplinary team. So one of our clinical pharmacists, he looks at any medications that have been filled, and he follows up with those patients who may not have picked up their statin medications. So he works with them in regards to medication adherence to see if there's any barriers or any hesitancies.
So I love all these patient-centered approaches that you described, Milibeth, and just a really quick plug for the pilot project Milibeth described. So really quickly, we are going to actually have a future Million Hearts Learning Lab on this topic. So this is actually trying to see if we can add messaging in addition to the number, add messaging to the lab result, both the result that goes to patients and the result that goes to providers, to see if that sort of promotes statin prescribing and a conversation from the patient to their provider about statins. So we'll see, more to come. We'll see if it works, and we'll be sharing that on a future learning lab. I have a couple more questions in the Q&A for you, Mike, about sort of point of care testing. So one of them is the result, or is using that acceptable for HRSA and UDS measures for quality measures?
I can't say for absolute certain. I don't think that, it does from the purpose of doing sort of chart reviews and looking at sort of that data reports, it's meeting those needs, but I can't say for sure about UDS metrics.
That's fair. The UDS metrics is really around, the one that I'm familiar with is around statin prescribing. So not necessarily the cholesterol screen itself, although I would be a huge advocate for that. I'm going to take one more from the Q&A, and then I have a wrap-up question for both of you. And this question actually, because Milibeth, you mentioned you're also doing point of care testing, you both could probably answer this. I'll start with Mike, and then we'll move over to Vito and Milibeth. So the question is, we used a cholestat a decade or so ago, so I assume that's an older model of point of care testing, but we got some really crazy numbers, probably related to technique, but significant enough that we quit using it. Have they improved the machine and or workflow such that accuracy is more probable?
Well, I guess I would have to say, yes, they have, at least in our experience. The results are very reliable. And we also, I think you have to perform sort of monthly quality checks with it also. And so I think that helps to ensure the accuracy too. And yeah, I remember those old cholestat machines too. And the technique's better, but it's still a bit tricky. And so, and as I mentioned before, until you get onto it, that can have an effect, not enough blood or those sorts of error problems. But once you get onto it, we've been pretty confident in the results. What have you found, Milibeth?
I agree with you. The results we're really confident with the results. And like you mentioned, it requires, constantly testing the machines to make sure that they're working, and also training staff to know how to use the machine appropriately.
Excellent. So the capstone question here for all of you, what is one piece of advice you would give to health centers who are interested in doing either of these techniques, telehealth with cholesterol management or point of care lipid testing? One piece of advice. I'd
have to say, just do it. I mean, it's effective. It works. Don't hesitate. A lot of, I'm not sure if this has been adopted all throughout telemedicine. Obviously it has to some extent, but it makes a difference, and it showed, the numbers speak for themselves. So it's just a matter of going, and we're all capable of doing visits, and telemedicine is an excellent tool. I don't see any reason not to do it. Or my thoughts.
And then my thoughts with telemedicine, I want to say, identify what works best for your patient population and your providers. Decide, what works for them. Like for us, simple and straightforward worked for our patients and our providers. So look at what works best.
Excellent.
Yeah, and I would agree. Just get started, and maybe don't feel like you have to tackle the whole problem all at once, but possibly identify one little segment that you can start working on, and maybe look at during the chart scrub for each day. Remember that we're going to kind of work on lipids and incorporate that into visits. And yeah, I agree. The telehealth is an amazing tool as well. And being out here in a frontier medicine setting, we often have some trouble with that, especially with our elderly patients. And so not every practice could do it, but we've actually had myself and our nurses do home visits and Zoom in the doctor to do the first televisit until people can get onto it. So be creative in the solutions that you can come up with.
Wonderful advice from all of you. So don't let perfect be the enemy of good. Take a chance, dive in, keep it simple. So these are wonderful pieces of advice. And I think, this is, dare I say, one of the silver linings of the pandemic, maybe, encouraged us to use some of these technologies that we may have been a little more hesitant previously to use. So thanks to all of you today. Great content, great questions and answers. We're going to transition here to sharing with you some resources that we hope you'll find useful. My colleague Rita is actually going to drop some of the links in the chat to make it convenient, but the links are also active on the slides. So when we share the slides with you afterwards, you can pick them up off the slides too. So the first one is really a roadmap tool. And I think what's so great about this tool is sometimes when you're trying to start focusing on a certain area, it's hard to know where to start, right? So this sort of gives a little bit of structure to you about here's sort of the low-hanging fruit things, the things to think about if you're really starting your cholesterol management journey in terms of QI. And then it builds on that once you've advanced a little bit beyond the basics. And then we've got some tools for patients. So how do statins prevent heart attacks and strokes? It's a patient education animation, and it's available both in English and Spanish. And then a partner tool, companion piece to that is the infographic for that, also available in English and Spanish. And then we have statins and lifestyle. So we have a lot of, we found out that a lot of our teams were saying that there's a confusion around lifestyle and statins. So for very high risk patients, the ones that we've described in this conversation and in the pre-work audio, lifestyle and statins go together. It's not sequential. So if you've had a heart attack, you need lifestyle change and you need a statin. Same with being diabetic, you need both. So this really explains how much risk is reduced by statin therapy, how much risk is reduced by lifestyle, and how important they are both to preventing heart attacks and strokes. And then we have the pre-work video that we talked about and referenced today. Really great video for clinician training. If that's the one I would recommend you share out with your clinical groups, your CMO newsletter. They're really great. It's a very short 10-minute, but I think it gets the point across very clearly. And then finally, we have a Q&A document, and this stems right from our Million Hearts work. These are the most common patient questions that surfaced, and we were trying to help care teams with answers, ready answers. So, take it, tailor it any way that you like, but I think this provides evidence-based, accurate answers to the most common questions. So with that, I think I'm going to turn it over to Rupi, who's our colleague at the American Medical Association, and she's going to explain how to claim CME credit.
Thank you, Meg. So here's information on how to claim your credit. There's an activity page link here on the slides. These slides will be shared with you. And once you click on that link, you'll be asked to sign in to the AMA EdHub site. If you don't have an account, you'll be asked to create an account, which shouldn't take too long. But once you're in, you just go ahead and hit the start button and take the quiz, select the appropriate amount of CME to claim, and you should be all set. Just a reminder that the deadline for claiming credit is December 28th, so right before the new year. And then after this date, the quiz will close and you won't be able to claim your credit. Here's just a summary of how to access or download your certificate of participation. Essentially, once you've logged in and completed the quiz, you should be able to select the transcript button on the top right and find your completed activity and select certificate to download and share as needed. And then this is just a friendly reminder of our upcoming 2 labs scheduled for next year. So the first one is on motivational interviewing for medication adherence. This is scheduled for January 18th. And then the next one is using bidirectional text messages to engage patients in chronic disease management, and that's scheduled for March 15th. I think that wraps up today's presentation and webinar. Thank you all. Thank you to the speakers. Thank you to our attendees for joining, and hope you all have a happy Thanksgiving.
Thanks, everybody. Yay.